winner this year. He will be speaking to us about whether OCT angiography can replace visual fields for glaucoma assessment.
Thank you, Martin. So, people who remember me here probably remember that I was the director of Laser Vision Center. So, what am I doing talking about glaucoma? Well, I actually do research on imaging in all parts of the eye, and glaucoma actually has been the biggest topic in terms of funding that I had over the years. And most recently, our group have been spending a lot of effort on OCT angiography in both retina and glaucoma, and I think glaucoma is going to be one of the more important applications. So that's why I picked this topic to talk about here. I still do laser vision correction. That's still a big part of my clinical practice. My topic is, can OCT angiography replace visual field? I certainly don't say that as mission accomplished sense, but as an aspiration or a confrontational goal. First I'd like to ask, how many of you are fans of visual field? Oh no. I was hoping that I would pick an opponent that people love to hate, but I guess there are some fans of visual field. I do have financial interest in terms of OCT and geography technology with regard to OptoView. So first I'm going to attack visual field. The problems with visual field testing are it's time-consuming and tedious. It's subjective, so it requires cooperation and attention from patients. And not all people can pay attention. Studies have shown that in one paper, 25% of patients are not able to give reliable visual field test results, and this worsens with glaucoma severity and older age. And many patients hate taking the test. Another limitation is that visual field don't detect the early stages of glaucoma well. If you plot visual field mean deviation versus neurofibrillary thickness, you'll see that in the early stages, there's very little change in mean deviation. And there's a tipping point, really with a moderate level of glaucoma damage where visual fields start to drop. And this tipping point is about 25 to 35% retinal ganglion cell loss. So this is so you need at least moderate loss by the time you can detect it with visual field reliably. Another limitation is the reproducibility of visual field. In the old study, 3 visual field tests are needed to diagnose glaucoma conversion. And when you try to monitor glaucoma progression, you want to find out who is progressing rapidly. So analysis have shown that for a rapid progressor losing 1 dB of mean deviation per year, if you want to detect statistically significant trend for progression, it would take 4.2 years if you take 2 tests per year. So even frequent testing, it would take quite a while. And that translates to 4.2 dBs of loss. So a patient would need to lose 62% of retinal sensitivity before you can be sure that they are rapidly progressing. And that might be a little late to intensify intervention. How about OCT? Structural OCT has become a standard in the glaucoma clinic, and this happened in the first decade of the century, according to a paper by Josh Stein. And by now, OCT is actually used more frequently than visual field, according to the AAO's IRIS registry. So how well does structural OCT do? Well, it is able to detect early damage, probably a little bit better than visual field, but the sensitivity in pre-parametric glaucoma is still poor, as you can see here. It's certainly below 50%. And structural OCT also is poor in the later stages in detecting change. There is a floor effect where in severe stages, the damage is so severe that you don't see much change in at least in the overall nerve fibular thickness with further disease worsening. And with the advanced imaging for glaucoma study data set, which follow a large group over 5 to 10 years, we show that structural OCT is actually very good at detecting progression in the early stages compared to visual field. But it actually doesn't detect progression with as good a sensitivity of compared to visual field in the later stages. So there's a need to go beyond both visual field and structural OCT. And this has become possible now because OCT has become so fast that we are able to go into perfusion measurement. There's a Moore's law for the speed of OCT scanning, where we see that the speed doubles about every 2 years. So compared to the original prototype that I and colleagues built in the very beginning, where it ran about 40 A scans per second, it's about 10,000 times faster now. So that means not only can you take a whole full volumetric scan of the back of the eye, you can actually go into the 4th dimension of time and perform repetitive scanning at the same place to compute motion and blood flow. And we call that OCT angiography. OCT angiography actually has been in the literature since 2006, but to bring it into the clinic requires a very efficient algorithm and fast OCT systems. And both of the commercial, earliest commercial algorithm actually has been developed in Portland at OHSU by Huang's group, and also in our group that turned into the Zeiss and OptiView systems. By now there are actually quite a few choices in the market for performing OCT angiography from OptiView, Zeiss, Heidelberg, and soon from Topcon. So now that we have this tool, OCT angiography, where in the eye should we look for glaucoma damage? Well, the usual suspect would be the disc, parapapillary retina, and the macula, of course. So the first target we investigated was the optic disc, and as you can see, there is damage in both the superficial nerve tissue and also deeper down in the lamina verbosa. How about in the retina? Well, the retina is actually fairly complicated. With projection resolved OCT angiography, we can see 4 different plexuses in the normal human retina. One supplying the nerve fiber layer, and others supplying the ganglion cell layer, and then there are 2 deeper capillary plexuses. And for glaucoma, of course, you want to look at the nerve fiber layer perfusion. And on wide field OCT angiography, you can see that the nerve fiber plexus is highly correlated with nerve fiber layer thickness It's absent when the nerve fiber layer is less than 18 microns, and it's actually stacked several layers thick when the nerve fiber layer is thickest, about one layer each 47 microns of nerve fiber layer. So looking at the different plexuses, we found that by focusing on the nerve fiber layer plexus around the disc, you can optimize the visualization of focal loss and also optimize the detection of glaucoma. AROC can be as high as 0.98 in differentiating a group of mostly early parametric glaucoma from normal. That's from a paper we just published. And we found that a slightly larger scan, 4.5 millimeter, is better than the smaller 3 millimeter scan because these defects are often most pronounced a little bit further away from the disc. And you can see that in the macula, the glaucoma most often affect the superficial vascular complex. And this can be shown statistically. And by focusing in that layer, you can best visualize focal defects and again achieve a high sensitivity and specificity for glaucoma diagnosis. Some groups have published macular OCT for glaucoma diagnosis using smaller analytic areas, 4 millimeter or 3 millimeter, and they have found poor diagnostic accuracy. And I think that's because they're really missing the regions that's most often affected in